Good morning, everyone. We're going to get started if you'd like to take your seats. Good morning and welcome. I am Joe Ruffalo. I'm the general manager of The Hill, and we'd like to welcome everyone here in person and that is joining us online for an important discussion today about Medicare and drug pricing. Time to think differently. I'd like to thank our sponsor, Alliance for Aging Research, for their support for this important discussion today. We're here today because the landmark 2022 Inflation Reduction Act, or IRA, has already helped people eligible for Medicare save on healthcare costs and vaccines and insulin. But as with anything in Washington, that's not the complete story. Increases in utilization management tactics, a guiding framework of health insurers and hospital systems to mitigate costs, are emerging as an unintended consequence of the IRA. Other provisions are starting to shift research dollars away from some medicines and towards others. At the same time, the Centers for Medicare and Medicaid Services, or CMS, are tasked with finding $98.5 billion in savings over the next decade, and to do so while prioritizing equitable patient care. What are the lessons learned from the first round of Medicare direct negotiation, and how can CMS improve the program in year 2? How should Washington address the unintended consequences? What do beneficiaries need to know about for their 2025 drug plans and open enrollment later this year? And how should all stakeholders begin to think differently when it comes to Medicare drug pricing and patients' best interests? We'll begin to answer those questions in a couple of minutes, but a few housekeeping issues before we start. If you are here in the audience, please silence your cell phones. But we do encourage you to join the conversation online. You can follow us on Facebook, X, and Instagram at The Hill Events using the hashtag TheHillHealth. And with that, I'm delighted to introduce our first guest, Congressman Scott Peters, a Democrat from California and a member of the Energy and Commerce Committee. And he joined Steve Scully, contributing editor to The Hill. Welcome.
Joe, thank you. Thank you all for being here. We have a terrific lineup, a great discussion, and really appreciate it. No better person to kick it off than Congressman Peters, so thank you for being with us. There is a real debate within your own party on the issue of drug prices, so let me begin on that point.
Okay.
So let's talk about the debate.
Well, there is and there isn't. We set out a couple Congresses ago to achieve an objective of capping the price that seniors would pay at the counter under Medicare at $2,000 a year to make sure prices don't increase faster than inflation, and that's what we did. The wrangling was in how we got there, which I was a part of, because the initial proposal, H.R. 3, would have made drugs eligible for negotiation the minute they came out. So think about what that does to the interest in investors. We'll just go back a little bit. We've spent about $45 billion a year in NIH in basic science research that doesn't produce drugs. The comparable number in the private sector, what they spent in 2018 was $102 billion in research. Why do private companies do that? Well, they do that because they think they can make a return. If they can't make a return, they won't make those investments. An investor is looking to get money back on his or her money is going to say, if I can't get a return on drug investment, I won't invest. I'll invest in real estate, something where I'm going to make money. And the problem with H.R. 3 would have said to investors, sure, if you come up with this blockbuster drug, that's good for you, but we might negotiate the price the minute it comes out. You won't have the typical patent period of time to make a recovery. So all I did, it seemed like a small thing, but was not, was I said, no, I'm not going to support something that doesn't provide that, retain that incentive, and provide a period of time during which people who've invested in drugs can get that money, can get a return. And you have to be conscious of the landscape where 95% of drugs fail. It takes $1 billion to get drugs to market. If you don't provide some return, that you won't have that investment. We've kind of seen a little bit of that coming out of how we set it up. But I'm really happy that I told a pharma CEO, I said, look, I said, I'm the doctor that had to amputate your leg, but we saved your life. Mm-hmm. We didn't kill the industry, which we were on the verge of doing, and I think just by a few votes did not do. So, we came up, we did achieve, and this is the thing, the bottom line, we did achieve the objective we did of protecting patients at the counter, $2,000 a year. We also added a cap on insulin spending at $35. So we provided the same relief for seniors that we set out to do at the beginning.
But Joe mentioned the number $98.5 billion in savings. How do you get to that level? How do you reach that level of savings?
Well, through negotiation. I think one thing I also I talked about but didn't get a lot of press is that at the end of the patent period under the current law, there was a lot of abuse, there was a lot of extensions. Some drugs were getting this protection for years and years and years. There's no reason for that. Once you've made your money, Humira was the big example. The thing had been extended out for a long time. There's no need for that kind of protected profits. So when you do negotiation after the appropriate amount of time, you save a lot of money.
So, Congressman, I have a niece who has a rare disease. Mm-hmm. The drugs are expensive, right, but it has saved her life. How do you deal with that issue when you have drugs that are very precise with diseases that are not common?
Well, you have to realize the choice is the choice you want is having an expensive drug and having to figure out how to pay for it, not having the therapy.
Right.
And the point I was trying to make in that whole discussion over drug pricing is if you don't provide investors the incentive to make the investment, you're not going to have the therapy in any case. So we should be talking about ways to pay for those kinds of things, but we should make sure that we appreciate this ecosystem where the government invests in basic research, the private industry turns that into therapies, and rare diseases is a really good example of the kind of thing we have to keep our eyes on after IRA. We don't want to have undercut the incentives to deal with diseases where, unlike Crestor, there's a huge market. Everybody's on a statin. You don't have to make a lot of money on each pill to get a return. But if you have a disease that has thousands where we have thousands of patients, to make that return, it has to be expensive. I also think we should think about the value of the innovation to government. For something like hemophilia A. The treatment is $1 million. If you could come up with something that cured hemophilia A, which is what we're talking about, for $500,000, that's actually a good deal. Mm-hmm. I think when we look at things like Alzheimer's too, that's not a rare disease, obviously, but
sadly, it's becoming much more common.
It's going to cost us trillions of dollars. So if you can pay for a therapy that would cost you $1 trillion instead of $10 trillion. Again, $1 trillion is not a lot of money. Whoever invents that should make a ton of money. We should tax those individuals appropriately from a democratic perspective. But we should provide that incentive, and we should celebrate it, and we should think about the value to us, whether we can save money.
So let's talk about insulin as an example. You keep using the word negotiate, and obviously there had to be negotiations to get the price cap at $35 per usage. How did we get to that point? And take us in the room as government officials, Medicare, Medicaid officials are sitting down with drug CEOs, the pharmaceutical CEOs, to get to that point.
That's not where it came out of. I'll tell you exactly where that came from. I told Nancy Pelosi and Frank Pallone at the beginning of the term, I said, listen, I'm not going to be able to support this. We had the trifecta. We had Democratic control of both chambers and the presidency. It looked like they were going to try to do this through reconciliation. I said right off the bat, I said, this is going to kill the industry. I have 70,000 people in life sciences in San Diego, 1,000 companies. I'm not going to do something that undercuts them. I'm going to come up with an alternative. And I came up with an alternative along the lines of what we ended up with. And I also proposed a $50 a month insulin cap as part of that. And the discussions with the White House came back and they said, would you be okay with $35 a month? Of course I'd be okay with $35. The only thing, you save a little bit less money if you're paying it down to $35 than $50, but that's how that came out. But it's just, we had heard so much about insulin being too expensive for folks, at least in the Medicare side, we could deal with it in that way, and that's how that came out.
Which is exactly why you're here to kick off this program, thinking differently about prices, and that's the topic of this conversation. Yeah. How should we think differently, not only now, but over the next 10 to 20 years, especially considering the fact that every day there are 10,000 baby boomers who are retiring, and more prevalent, more of a need of drugs and health care?
One is we should keep this industry American. I mean, we're in the process of spending $50 billion to bring back chips, which we invented in Silicon Valley. That's why it's called that, right? And we let that industry go, and now we realize it's important to our own security. We have this industry here, and I think we should really not take it for granted. I thought that the Democrats' initial approach was really dangerous for the country. Another thing we should think about is value over time. So in the way we budget is really crazy. No one would do this, Steve. You would not come home and tell your family, we can save $10,000 by not fixing the roof, because you think about the $30,000 you're going to lose next year when it rains. But we only think about this year, right?
Why is that?
We have this scoring system here that's so artificial. It says it thinks of every expenditure as this year's money. It doesn't think about what you'd save over time. Today we have things like whole genome sequencing. It's amazing what we could find out today if we spend a little money today about what these patients are going to go through. Mm-hmm. Lost income, whatever. I can give you examples of what happened at the Baby Bear Project. Look it up at Rady's Children's Hospital, where they sequenced kids who are having these difficult diseases, and they were able to find out right away what it was, which, instead of going through this diagnostic odyssey of going from specialist to specialist, what's wrong with my kid? We have those technologies now, but innovation might cost more money up front, even if it saves money down the line. So we have to think about a different way for budgeting and healthcare in particular, because the savings are never going to be this year. Again, I think we should celebrate the innovations of this industry and make sure that we keep it American.
So let me just take that one step further, because are there best practices in other nations that we can learn from? Because to your point, whether it's a budget issue or thinking about healthcare, we're thinking maybe 6 months or a year down the road, not 5-10 years down the road.
I'm not really familiar with how other countries budget, but this is our thing. We're going to have to invent how to handle it, how to care for it, how to keep it prospering, and how to keep it serving Americans. So in the Budget Committee, which I also serve on, we're talking about how to think about balancing the budget over time. If we don't think about the future costs of all these diseases as part of that calculation, I think we're going to miss the mark. And I think from a budget perspective, within the building, within the Capitol, we should figure out a way to give credit for future savings.
But as you look at the industry holistically and you see the innovation that we have in this country when it comes to drugs, the good news is Americans are living longer. The bad news is it's getting more expensive to live longer, and drugs are a big part of that.
There's a lot of components of healthcare expenditures. Hospital costs are up. We are talking now about pharmacy benefit managers and the middleman, the so-called middleman in the drug chain. While drugs are certainly part of the expenditure, I think we've taken a big step in saving money on that. And you said $96 billion. I thought the estimate was $300 billion. So that's good.
It's a lot of money, regardless.
A lot of money, and I think good on us for taking that first step. But I think most people have characterized what you do about healthcare expenditures as a lot of small steps. There's no big magic bullet. But that was the big one. The IRA really, it's going to save us a ton of money using negotiation for the first time on behalf of Medicare. We're starting the negotiation process now. Mm-hmm. We won't really find out kind of what happens in the room until afterward. They're going to issue after a negotiation report. We'll look at that. We also ought to make sure we're getting the bill just right. Any huge undertaking like this, whether it's the ACA or the Trump tax program or this thing, we are going to have to go back and tweak, see how it's working. We're already finding that there's some maybe distortions in the incentives we created that we could correct.
Well, let me pause there. What is the biggest fix that you think needs to be made right now with ACA?
There's two. We set out a period of 9 years for small molecules and 13 years for large molecules, biologics. I just saw a graph yesterday that the investment in small molecules in neurology has gone almost to zero. So and the investments in biologics has gone up. So maybe we clear up that disparity. We don't want to disincentivize the very things that I think we wanted to encourage. The other thing is with respect to orphan drugs, if you've got a drug that you want to find, you have some use for now, but you want to you find other uses for it. There's only protection kind of for the first bite. After that, there's you get negotiated right away, so there's no incentive to invest in the use of existing drugs for new diseases, orphan diseases in particular, rare diseases, I think are the things you're talking about.
Yeah.
That would be an easy fix. But I think we're in pretty good shape, and let's see how the negotiation goes. And there may be learnings out of that as well, but these are pretty minor in the context of what we've achieved, which is pretty amazing relief for seniors at the counter.
But when you look at Obamacare, ACA, has it met the expectations that you think President Obama, Democrats first put in place with regard to drugs and health care?
I'm old, but I'm not that old. I wasn't here for Obamacare, so I don't know what the expectations were.
But you talked
But I would say,
policies.
look, I mean, the number of insured people is much higher. And, I came in and there was all this talk about Medicare for all, and we have to go to the Canadian system. And I don't hear that anymore, given the lines and the expenses that are occurring in Canada and England. We got a pretty good system with some things we need to fix. And I think Obamacare took a pretty good whack at that and closed a lot of and improved it. And,
So there's no going back.
Oh, there's no going back. I don't think so.
Final question.
By the way, that would be great. I wish the Republicans would declare they're going to repeal Obamacare again. That was pretty good for us.
Well, it did work for them in 2018.
Right? Yeah.
Final question, because you're one of those members that this is your issue. You are passionate about this. Why?
Well, I come from San Diego. We have 70,000 people in life sciences. We have 1,000 companies. I have colleagues who tell me all the research is done at the NIH. But I go in these companies and I meet all these scientists doing really important things. And I'm just so proud of it. And we have big companies like Pfizer and Eli Lilly and Johnson & Johnson. They're great employers. But there's a lot of small, scrappy outfits trying to solve hard science problems with private risk capital. And, I came here to represent San Diego. I'm not going to let them blow that up. And I think we came up with a pretty good solution. And I do think that in our economy in San Diego, but in the United States economy, the innovation economy is so important. This is such a big part of it. So, we're one of the 3 top bio clusters in the country, but we have Qualcomm, which is going to design a lot of these chips. It's really important to me that America keeps this brain power, our piece of the brain power economy, because we're competing with people who want to take that. Particularly China. And so I don't like the idea of self-inflicted wounds. That's how I got into this. Right now I'm working also on permit reform, because we got all these aspirations to build stuff and we got all these laws that keep us from building stuff. But I can only take one fight against the Democrats at a time. So we're trying to. I do have this theory that leadership begins when you talk back to your own people. And I'm really glad it worked out like it did with drug pricing. I think we came up with a great result. Democrats are running on it all over the country. Now I think we should fix the environmental laws to modernize them for today, and that's my issue right now.
Final question. We're going to go a minute over, but unlike the debate tonight, we're not going to mute the mic.
Yeah, okay,
so
good.
You can continue. Broad question. The future of drug pricing in this country is what?
I wouldn't say it's settled, but I think it's incremental. We should make adjustments as we go along and see what we can do to make sure that what we've done really has achieved the objectives that we want. And I think we should expect a good discussion about that in the next few terms.
Just for the record, that was a phone. That was not a bell to cut you off. Congressman, thank you so much for being with us. Great to be with you. We appreciate it.
Thanks a lot.
Please welcome to the stage Congresswoman Miller-Meeks, a Republican from Iowa, doctor, and member of the House Energy and Commerce Subcommittee on Health.
Congresswoman, thank you so much for being with us.
Thank you. My pleasure.
Dr. Meeks. Well, first, your reaction to what you heard from your colleague a moment ago.
I have interacted with Representative Peters on a number of occasions, and I agree with some of the things he said, and I disagree with some of the things he said. From my standpoint, no, I am not going to try to repeal the ACA. So, Representative Peters, you heard that from me, and we also know I have no influence within my conference because I've taken on my leadership maybe on one too many occasions, which is why I had a robust primary. But, there are some things I agree with and some things I disagree with. I'm very concerned about the impact of the IRA on drug innovation, drug development. So it's interesting to talk about the need, desire for innovation in the United States, how well we do things, but at the same point in time, put forward and vote for and support a bill that can crush that innovation. And that's not just here in the United States. I've actually traveled abroad and was shocked when I had companies come and talk to me about the impact of the IRA on them, on foreign countries who do have a market in the United States.
So how do you strike that balance? Because you're right, we are innovators when it comes to drugs and pharmaceutical research. We are leading the world, and yet prices are high. So how do you get to that equilibrium?
Well, one of the things you do is start looking at the whole supply chain and where those costs are and where there's value. So one of the things that I've done is and I think Rep. Peters has also been very helpful on this front, is looking at the PBMs and looking at the whole marketplace and the supply chain. So my desire is not to end pharmacy benefit managers or PBMs, but certainly when you look at the marketplace from a pharmaceutical company that has the research, the development, then the clinical trials, then FDA approval to go through that entire process and the capital investment it takes to get there, then to get a drug to the market. And then you look at the PBMs, which are this opaque intermediary, middleman, and what value do they bring? And there is some value. Are they inflating drug prices, which they are? I thought that we would get PBM reform earlier, but we've got a couple of bills on that. So one of them is the Drug Act. But from the patient standpoint, so I look at this from both ends. One is the congressional hat and what we do in the budget, what we do on cost, what we do on making sure people have the newest medications, the newest types of medications. And I think Rep. Peters mentioned biologics. So biologics or immunotherapy or gene-guided medications, all of those are going to cost vastly more than the antibiotics that we started with 60, 70 years ago. And so the congressional hat, but then the doctor-patient hat is, how do you get cures to individuals? How do you get medications in people's hands, and how much are they paying for that? So I think that there is reform we can do, and one of the big criticisms I had with the IRA is, although it's claimed to be bipartisan, there was no Republican input. And I think one of the things both parties should learn is to put forth huge policy changes, huge programmatic changes. It's best done with input from both major parties, and they're more long-lasting. So I think that's one of the things that I don't agree with Medicare price negotiations. If you'll think back to Medicare Part D, when our federal government and taxpayer dollars went to pay for drugs, that was not part of the Medicare program. People didn't contribute or put into the Medicare program for drug coverage, so that this was added. One of the benefits of the way that Medicare Part D was done, i.e. money going to the patient rather than money going to another entity or a third-party payment, was, if you'll go back and look at what happened immediately after it passed was that Walmart offered $4 generic drugs. That was an immediate impact. Now, they wanted to do, our currently minority party, but the Democrats wanted Medicare price negotiation in Medicare Part D, and it didn't happen. But what did happen was much more powerful, and that is money in the hands of individuals, money in the hands of patients, then looking at where their drugs are, where they get their drugs, how they get their drugs. So Walmart started it, and it was followed by everybody else. And that was hugely powerful in reducing patients' out-of-pocket costs.
But why not have the federal government at least have a role in that process of negotiating drug prices?
Because I think what happens is that they artificially set a level when if you had market-based competition, you may have that pricing lower. And the other thing is, in both, you said this in your last time period, was that it has already had a dampening effect upon what's being developed, what's being innovated, what's being produced. In addition to which, I've had work where I've had individuals that are getting their medications from the VA. The VA restricts the formulary, and so I may want to, as a physician, in concert with my patient, discussing with them, want them on a particular medication, have them stable and compliant on a particular medication, but the VA changes the formulary and restricts what access to medications they have. So, and especially in rural areas. So I have a district that is both urban and rural, but I mean, I can go 400 to 600 miles in a day when I'm traveling my district. It's that far apart and that disparate. And so, you know, having those, you know, type of medication, what the impact is, those are part of the IRA. And we have yet also to see what the ramifications will be. So part of this is conjecture, but I can also say the concerns I had with the ACA, you know, have been realized.
But let me go back. You answered part of my next question, which is access in rural areas. Geographically, your district is how many miles? Roughly?
Oh my gosh, I don't even know. It's all of southeast Iowa. I do it by hours I'm on the road.
So when you're on the road, when you're talking to those people in the more rural areas, what are the biggest challenges that we're facing in terms of access, not only to health care, which is a big issue, but also to the drugs that they need? Twofold, and one is that because of the increase of the PBMs or pharmacy benefit managers in the supply chain of medications, and the fact that they restrict drugs that are coming onto the formulary or a certain tier, you have 80% of medications now come through the PBM marketplace, which typically mails drugs. They also reimburse a pharmacy or an independent pharmacy for a medication, often at a cost or a price that's lower than it takes that pharmacy. So what's happened is that small independent pharmacies are closing. They'll have clawbacks, so they'll have been paid for a medication, then the PBM will claw back what they paid. So they're ending up underwater. So as these small independent pharmacies close, you don't have access to medication. So maybe sometimes you can wait a week to get a medication in the mail, but often you cannot. So if it's the evening, or if this is the weekend, or what about a cancer drug? That your oncologist, you've seen the oncologist, they prescribe or they make a change. You don't have access to that medication until it comes later. And we're actually trying to address some of those things in legislation. And we have two pharmacists, Representative Harshberger and Representative Buddy Carter, both of who are working on that issue as well too. So access becomes a problem and an issue. The other problem with mailing drugs, and I dealt with this with my mother had Alzheimer's, and so the last 6-7 years of her life, I would drive back and forth between Iowa and Oklahoma to prepare all of her medications. And in concert with her doctor, there were some medications I, discussed with her doctor if she needed to be on them, and some not. I would still get 3 months supply of medication long after she was taken, and it's a waste of all that medication and a waste of money in the system, and no one even talks about that. Why 3 months?
Because typically a PBM or a mail drug will send people a 3-month supply, 90-day supply of their medications.
As a doctor and as a daughter, what did that experience teach you about your mother's care, the drugs that she received, and how it was administered?
Oh, that's a great question. I can just say I understand very intimately the frustration people have with getting drugs through the mail, getting them canceled, getting them sent back, taking care, and sometimes medications that are left over are narcotics, how to dispense of them, what's the proper way to dispense of them, and then just the frustration of, how many times did I have to call. And in this particular case, it was TRICARE, and I'm not knocking one individual company. This is across the spectrum. How many times do I have to call? And I have some knowledge of the healthcare system. So if you have no knowledge of the healthcare system, and you're helping take care of a child or an elderly parent or an adult that does not have the capacity to care for themselves, and you may be working and taking care of your own family, the amount of time you're spending on the phone or writing letters to correct things, and you're trying to be conscientious because we are all paying this cost. This is a shared cost that we all have. And so you're trying to be conscientious, you're trying to save money to the system so that there is money for newer drugs, innovative drugs, immunosuppressive drugs that are biologically or individually chromosomally genetically based. Because that's where the new cost is going to be. That's where the major cost is going to be. So it's very frustrating. And so I certainly understand people's concern, what they go through, but it's also what makes me such a passionate advocate for PBM reform and helping to lower that cost and helping to keep our small individual community pharmacies in place because they're there, they consult, they do other things. They deliver drugs for people, when they saw their doctor, they need a drug the next day or that day, and they add value.
Well, you know this, but my wife is a nurse, but as an advocate for your mom, you need somebody to be an advocate when you have somebody who is in declining health, who needs the drugs, because without an advocate, you get lost in a very bureaucratic system. Speaking of bureaucracy, you mentioned something earlier. We could spend the next 5 hours talking about Congress and the lack of bipartisanship and how the system is broken. On this issue in particular, it is a bipartisan issue because healthcare affects all of us. So how do we get to the point of reaching some consensus on drug prices, on healthcare in general, and on legislation that both sides can agree to? Not necessarily this year, but certainly in the next Congress, regardless of who's president and regardless of who controls the House and the Senate.
Well, I think first is you start with the little things. So you start where you have consensus and where you can agree on things. The other thing that I think is important is for members to be together. So whether it is on, we did it, Energy and Commerce, this was international, but the Energy and Commerce Committee last year went to COP. The UN Climate Summit. And it was good, and it was bipartisan. It was good for us to go as a bipartisan group of individuals. So whether you have, small forays, small trips to go visit a nuclear power plant or to go visit a drug manufacturing, those, or when we went to the strategic national stockpile. So those, forays, those interactions with members outside of the halls of Congress, in a setting where there's not as much pressure, I think is very helpful for us to be able to get together, talk about things. And you don't even have to talk about bills or legislation. You just talk to one another as human beings. And I think those things are very helpful. We have, I wouldn't say that there was always bipartisanship on PBM reform, but it certainly has turned into that. When I came to Congress in 2021, sworn in January 2021, I started talking about PBM reform, found allies and Representative Carter and Representative Harshberger who also wanted to do that. But I can tell you, in talking to Representative Carter, this has been something that he's been at for over a decade. And so, utilizing that knowledge and expertise that each one of us bring to the table, all from a different circumstance. As you heard from Rep. Peters, because he has entities in his district. And so it's important to his district, it's important to the constituents he served. He brings a certain, value, certain knowledge and expertise that those of us that don't have those type of companies in our district. So I think more conversation, more talking, more willingness to engage, and then members being together where they can see each other as individuals, as human beings, not part of a party. And then there's a whole lot of other stuff beyond that that I'm not going to get into. So.
But two final quick points. I talked to Senator Bill Cassidy about this issue. He's a doctor. Who are the advocates? Who do you look for in the House and the Senate that have the medical background to address these issues?
I think that we've found, when we go to look at bills, so we have, kids accelerating access to care, in the Medicaid improvement. So we actually look at both other physicians. So you have Dr. Barrow, Dr. Ruiz, Dr. Sherrill, and then other people that are advocates. So you search out those, you find people that you can work with. They'll ask you about being on a bill. You'll ask them about being on a bill. So then you learn as you're in Congress, those individuals who you think that you can work with, and also individuals that you can trust. Part of this is trust. When someone says they're going to be on a bill and they're going to co-sponsor a bill, then do they turn around and then vote against the bill in committee? So you learn those.
That would never happen.
I've never done that, but I'm way too candid. And I have no poker face, so people usually know if I support or don't support something. Those things you learn with time and being in Congress. And then you talk to other people that are also in that space and can help you to say, this person might be, amenable to this. So you learn who to work with and who to avoid.
Final question, 30 seconds. The next panel is coming up. The future of drug prices is what? Same question I gave Congressman Peters.
First and foremost, PBM reform. I think that has, to do PBM reform, our drug pricing bill, our drug bill on spread pricing, that bill alone would save our government $636 million, and it would immediately have an effect of lowering prices for individuals.
Congresswoman, thank you very much. You're going back to your district this weekend?
I'm going back to my district this weekend.
Safe travels. Thank you.
Please welcome to the stage Michael Ward, Vice President of Public Affairs and Government Relations at the Alliance for Aging Research, joined in conversation with Joe Ruffalo.
Michael, good to see you. Thank you for being here today. We just heard congressional perspectives on the Inflation Reduction Act, but stepping back from the long-term considerations, what should all Medicare beneficiaries be on the lookout for heading into open enrollment in October?
Yeah, well, it's really kind of a game changer this year. We're seeing the two major provisions of the IRA go into effect, which Congressman Peters talked about, the $2,000 out-of-pocket cap. So this is the first time ever in the Medicare program that there's going to be an upper limit on what Medicare beneficiaries actually pay for prescription drugs. So, in prior years, we would see, patients that had expensive drugs, such as in the oncology space, they might spend $5,000, $6,000, $7,000, even more per year, and so that's not really kind of sustainable from a patient perspective. So that new $2,000 limit is going to be really important. The second benefit that we're excited to see is that for any cost below $2,000, that beneficiaries will have the ability to pay that through zero interest payment installments, and this is called the Medicare Prescription Payment Plan. So this will, I think, $2,000 still a lot of money, right? So I think coming out of your paycheck all at once is, or the money that you have in your bank account is a significant barrier. It may cause issues in terms of whether someone decides to fill their prescription or not. And so we're hopeful that this program will, allow people to actually be able to go up and afford their medications, because they don't have to pay at the pharmacy counter, but they'll be billed later by their insurer. So on the flip side, though, I think there's some things to be aware of as well. There are real challenges with the way that the Inflation Reduction Act, some of the pay for, is not just price negotiation. It's for the beneficiaries that had expensive drugs that they're paying those $5,000, $6,000, $7,000. A lot of that financial risk is being shifted to insurers. And so insurers now kind of have an incentive to try to figure out where to make up that money on their own bottom line. And unfortunately, I think one of the things that we're likely to see is increased utilization management. So I think we've probably all experienced where our doctor needs to call in and get approval for a drug. That's called prior authorization. And a more severe flavor of that is called step therapy, where your doctor may prescribe you a drug, but your insurer says you need to try these other drugs first, and they have to not work before you get the drug that you're initially prescribed. And so it's going to be really important going into open enrollment with all these changes happening for beneficiaries to examine to see if the drugs that they're on are covered and if they're affordable. Honestly, Joe, there's not a whole lot of turnover. Like once a Medicare beneficiary picks their drug plan, when they end the program, they usually stay on it. But with all these changes, it may not be the case that the plan that people have been on is necessarily like the best option for them moving forward. And so we really are encouraging people to shop around this year. If folks are watching and want to take away, I think it's really important in their open enrollment for individuals Medicare to shop around and to also make sure when they're doing that, use Medicare Advantage Plan Finder, call their plans to make sure that the drugs that they take are covered, and make sure also that they're not subject to kind of these additional requirements that may interrupt their access to care.
The Alliance has worked to raise awareness, and you mentioned some of these, the out-of-pocket maximum and Medicare prescription payment plan, both of which will be fully implemented in 2025. But what level of awareness is for all of these?
Yeah, I think it's a challenge right now, quite frankly. It's the $2,000 cap is less of an issue because it's an automatic thing. So if an individual spends $2,000 out of pocket, then they'll automatically be cut off and they won't have additional out-of-pocket expenditures. So that's relatively easy in terms of, if there's not appropriate education done, that that it won't have kind of an adverse effect. I think the bigger challenge is around the Medicare prescription payment plan, because unlike the cap, this is an opt-in benefit. You have to tell your insurer that you actually want to use this plan. And you have to do it before you get to the pharmacy counter. Like if you go up to your local Walgreens and say, hey, I'd like to use this payment installment plan, it won't, you'll have to have to come back later, basically, because it requires at least 24 hours before you fill a script for that to go into effect. And so this is going to require a lot of education. CMS is doing some, but honestly, I think that they may not have the budget to do as much as they may hope. And so groups like the Alliance and other patient groups are doing efforts to help raise awareness, creating our own materials to come alongside what Medicare is creating. But it's really going to take not just patient advocacy groups, but many others in the healthcare space to really make sure that beneficiaries are well positioned to take advantage of these new benefits that the IRA provided.
Manette Health just released a white paper today that was sponsored by the Alliance that looks at issues you mentioned around incentives for prescription drug plans to change what drugs they are covering. What else is covered in the report that we should all be aware of?
I think the high-level takeaway, and there's an executive summary for those in the room and a QR code that you can go to the report on the back, is that kind of with all these challenges that we talked about, both with plans having more incentive, they're at higher financial risk due to those changes that are coming this year. To be honest, we're also seeing some similar dynamics at play with the drugs that are subject to price negotiation. There's going to be some incentives to move these drugs around in a way that may make them more expensive or harder to access for beneficiaries. And so this report really digs into those issues, explains kind of what's behind the factors that are driving this. And I think one of the things I'd like to take away from the report is that there are actionable things that CMS can do now, that the Medicare program can do now. It doesn't take congressional action because we know that is a long road to hoe, and given the current political environment and that we're in an election year. And so these are actionable things. It's like greater transparency, for beneficiaries. That way they can see if there's like utilization management techniques that are being used by insurers. It's also things like appeals. So if you are denied access to a medication by your plan, you can use an appeals process by Medicare, but very few beneficiaries use this. It's cumbersome, but if you do use it, you tend to have a very successful experience. So making that less cumbersome, more accessible, and also just for the prescription drugs that are subject to negotiation, which kind of by definition, Medicare is saying they're paying a fair price for, that they're placed on a tier within a drug's plan formulary that's not overly expensive for patients. And so I know that I was excited to see Manette's findings and some really great recommendations, and I know that we'll be asking CMS to act on some of these, and we hope that others will as well.
Excellent. What else should we know about how CMS is implementing drug pricing changes before we go?
Yeah, well, I'll say that Representative Peters took a lot of the points I was thinking about in this space because, with whether it's the IRA or any other huge piece of legislation, there's just so many moving parts that there's bound to be something once you get in there and start implementing it that it has some consequences, some aspects to it that didn't quite turn out the way that we wanted, right? And so I know that Representative Peters talked about the difference between a small molecule drug, so these are like the drugs that you would pick up in a pill form at a pharmacy counter versus drugs that are administered in a doctor's office that you have to go there from we represent older adults, and so if you're older, you may have more mobility issues, challenges getting to a doctor's office. Frankly, those medicines also tend to be more expensive than pills, and so I think that there's just some incentives there that we're concerned about because those drugs, those pills, are actually disadvantaged compared to those that you receive in a doctor's office, and so I know that there is some. And I think we're just concerned, long term also about what the impact that this will have on research and development. Really, we hope that research and development is guided by science. It's guided by kind of what is the best mode of delivery, both in terms of efficacy of a drug, but also in terms of convenience for a patient. And we don't want that to be overridden by payment incentives. And so, we're also seeing similar issues in the orphan drug space for these rare diseases. That if you do initial research for an additional condition that is approved by the FDA, however, if you're approved for a second condition, then you're subject to negotiation. So it really it really disincentivizes doing that additional research into an area where a drug could be really effective and it could be a cure or really helpful for that patient population. So I was really encouraged. I mean, I know the challenge around the IRA is that it's still being implemented. There's reticence to revisit it. And while it's still being implemented, there's political challenges, but it was really, I think there is a developing consensus and awareness, as Congressman Peters noted, even among the Democratic side, which passed the IRA, that there are some tweaks that are necessary, and that we are hopeful that that momentum will continue to build in the years to come to make those changes.
That's great. Well, thank you, Michael. A lot of great information. Appreciate your insights today.
All right. Thanks, Joe.
Thanks.
Please welcome Steve Scully back to the stage, joined by our panel of experts. Dana P. Goldman, Professor of Public Policy, Pharmacy, and Economics at the University of Southern California and Founding Director of the USC Schaefer Institute for Public Policy and Government Service. Dr. Jennifer Ellis, Cardiac Surgeon and Co-Chair of the Health and Public Policy Committee of the Association of Black Cardiologists, and Deneen Ciccone, Vice President of Policy and Advocacy at Cancer Support Community.
What a great panel. Let me begin. I have to begin with the obvious. Is that a prerequisite for an USC
Yeah, absolutely.
dean to wear the colors
Yes.
and the sneakers?
These are my USC kicks, so
Well, thank
I'm
you.
representing.
Thank you very much for being with us. Let me just follow up on all that we've talked about this morning, because one thing is clear. When it comes to drug pricing, Professor Goldman, it is not one size fits all. How do we navigate that so we keep prices low, but also make it accessible and spur the innovation that we need?
Yeah, you've hit on a fundamental challenge, and it is very important to understand that there are dramatic differences for how developers are going to respond. Representative Peters comes from a district, as he said, which a lot of the companies are small. They're investigating things like gene therapies. There may be very small patient populations who are affected by those. And one of the things about the IRA, and of course we all know that the details matter tremendously, it kind of says to people who develop drugs for these ultra-rare diseases, orphan designations, that if you make too much money, if you find other ways to use your drug, you're suddenly going to be subject to negotiation, and we're going to claw back some of your profits from you. So think of that from the perspective of a developer. They say, maybe I want to focus on very rare things and not try to expand the people who are accessible. And that's not good for patients. Now think about the other side of the distribution. Think about, for example, medications to treat obesity. I mean, this has been a remarkable development. It may be one of the most important public health interventions that we have discovered in the last 30 years, and probably could have health effects, if you believe our models and others, that would be similar to the impact of getting people to stop smoking. And yet we are going to tell people who are innovating there that there's the potential, and we don't know yet what the prices will be, that if you develop something so profitable that, again, we are going to claw back. So I do worry about the possibility that ultimately, and we do need to take the long term, it will be, while patients may see a lot of benefits at the counter today, long term, there will be access to treatment will be hindered.
Let me follow up on that. And Deneen Ciccone, I know this is one of your areas of expertise. So to that point, how do you maintain the costs but maximize innovation and creativity and research?
So I think one way you can do that, a couple ways you can do that, from a patient perspective. I always believe it's important, when developing drugs or having these conversations, that patient input is at the beginning of the conversation, and that what matters to patients are a part of these decisions. And what I mean by that is, by including patients in these conversations and understanding what matters to them and what their preferences are, their experiences, you'll know that, a patient might be willing to pay a little bit more for a drug that may improve their quality of life, as opposed to another drug that maybe doesn't, or they may be willing to pay a little bit more for a drug that lessens side effects. And that's an area that's very important for consideration as well. I think another area you have to be really careful about is utilization management with respect to cost. And that's one area where we can see that inappropriate uses of utilization management can actually increase cost to the system. We think about step therapy as one approach, that fail first approach, that does not allow that patient to receive that medication that the physician initially wanted. That can cause downstream costs to the patient, to the payer, and to the system. And so that's another area that I think we need to think about really carefully, is how utilization management is being implemented. And lastly, with respect to innovation, there are a couple of bills that we think really address some of those unintended consequences that can support innovation. And it was talked about a little bit, the pill penalty, or the small molecule drugs versus biologics. Cancer support community, we support the EPIC Act for the very reason that we know that there are more cancer drugs that are being approved that are small molecule drugs, and we also know that in a lot of ways it can mitigate some of those disparities and inequities that individuals may experience versus an infusion or a biologic. So we want to encourage and incentivize manufacturers to continue investing in that space, and we don't want to discourage innovation for small molecule drugs. We also support the Orphan Cures Act for that very reason. We don't want to disincentivize or discourage innovation. At Cancer Support Community, I always say we have the privilege to serve patients, caregivers, and survivors that are impacted by cancer by meeting them where they are, offering psychosocial support. And what I hear from caregivers and patients, what really resonates with me, particularly in the rare cancer space, is rare disease innovation is so important in a couple of ways. One, when you're told you have a rare cancer, at one point the medication may stop working and you need to have access to something else that works. And secondly, we're individuals, and how we may respond is very individualized and different. And so there needs to be a robust array of medications that are out there and accessible. And so some of those disincentives that we talked about with respect to the Orphan Drug Act and EPIC Act, I think, those are tweaks to the IRA that could really go a long way to preserve research and development.
There's a lot there to unpack. Thank you for that. But Dr. Ellis, let me just take one aspect of it when it comes to the public policy aspect, because we heard from a Democratic and Republican member of Congress, Democrats praising the IRA, Republicans concerned about the unintended consequences of the IRA. So what are your thoughts about that? Are there unintended consequences when it comes to drugs and healthcare and prices through this legislation?
Well, absolutely. There are always unintended consequences because we just don't have enough vision to know how things are going to lay out. But I do want to push back a little bit on some of these orphan drugs. I'm going to say something that's a little bit unpopular probably. The number one killer in the United States is cardiovascular disease. You are more likely to die of cardiac disease or cardiovascular disease than HIV, cancer, accidents, gun violence combined. Everyone in here is more likely to die of heart disease than something else. If you have survived breast cancer, or if you've had breast cancer, you're more likely to die from heart disease than from breast cancer. So when we're talking about some of the consequences, these unintended consequences, one of the things that we were talking about, the Walmart drug price of $4 for a pill, well, that was an inconvenient pill. So like this, there was a beta blocker that was $4, but you had to take it 4 times a day. And if you're not compliant already, so one of the things when people come to my office, I would say, bring your pills. And you would look, and it's a 30-day supply, and there are 8 pills in there. So you know that they missed 12, they missed 8 weeks worth of dosage. So when you're looking at some of these talks of unintended consequences, yes, it was definitely cheaper in the long term because the long-acting pill cost $75. For a 30-day supply, the short-acting was $4 for a month. So which one are we going to try to get to the patient? And then if you look at an underserved or less served population, where it is less trusting of your physician, less trusting of healthcare, and then you're trying to change medications around and you're making adjustments. One of the frustrations, especially in the African American community, is if a patient has a side effect, so you're talking about willing to pay more, they have a side effect, more often than not, they do not come to the doctor to say they have a side effect. So one of the things I would have to say for a statin, if it bothers you, do not just stop it. Come and tell us. We will give you a different one. There are about 30 different kinds. We will find one that won't bother you. And patients will be like, oh, I didn't know that was an option. Instead, they will just stop taking it and they won't tell anybody.
Is that just human nature?
That is, it's human nature, but it also has to do with privilege and comfort. If you are afraid to have not afraid, but if you are disinclined to confront or question your physician, and if there is socioeconomic reasons why you are especially not going to have those conversations, if you are in a very busy clinic versus a concierge medication set or concierge medicine service, you are less likely to say, why are you doing this? And this is one of the things that sometimes when you're teaching students, you have to make sure that they are aware of, because they just say something and they don't understand the impact that they can have. And especially on, like, if you talk to my grandma, if you gave her a pill, she wasn't going to question it.
You talk about obesity. What should the role of CMS be when it comes to obesity drugs?
Yeah, I think it is. When I first got started in this field, I remember going, I was working at the Rand Corporation. I was a health economist, and this was back, I don't want to tell you when, it was so long ago, but early 90s. And I went in and gave a presentation to CMS. And at that time, they didn't even cover drugs. I mean, it is rather remarkable that it took the United States until 2004 to pass something that would cover prescription drugs. And I went in and I thought I had done some brilliant analysis where I showed them that if they actually had covered antihypertensive medications, they could save, at that time, $50 billion a year, and in addition, reduce health disparities. And they said to us, yeah, but we don't cover that. And so, and they kicked me out of the room, and I haven't been invited back since, just so you know. So this is as close as I get. And so the point is that I think, when something like anti-obesity, and I served on the CBO's panel of health advisors for many years, and nothing upsets people who work on federal budgets more than if people live longer, because that costs them money in Social Security land. And so the discussion that you hear has nothing to do with what is best for population health. And so now coming back, you asked me about anti-obesity medications. When we discovered antihypertensives, everyone at the time was saying, look, just diet and exercise. Why do we need these medications? Well, it turned out now it would be malpractice not to use antihypertensive medicines. I think in
because
10
it's
years,
preventative.
Exactly. And our modeling has shown that it could save Medicare $250 billion because of reduced hospitalizations, all the sequelae that come from obesity. We're finding linkages with cancer and the like. And the fact of the matter is we have to figure out a pricing strategy. And the pricing strategy, unfortunately, is not the one in the IRA. The pricing strategy, in my view, should be one where, look, these drugs are much more valuable if you have diabetes and are at very high risk. We should pay you more commensurate with value. And in fact, I find it ironic, we talk about Medicare pricing, but we haven't gotten prices right in this debate because, when we talked about Hep C drugs, it was price per pill. That's not the price people care about. What we care about is the price for health outcomes. And that means tying prices to value. And I'm very worried that implementation of the IRA is going to be about, we just want the biggest discount off list price. And it's not going to be about how do we encourage valuable medication into the marketplace and how do we discourage innovation that doesn't do any good.
So let me follow up on that, Deneen. And we heard from Congressman Peters. I thought his analogy was terrific, that if you have a leaky roof, do you spend $10,000 to fix it, or do you let it go and then have $30,000 in damage? How do we rethink when it comes to drug prices, especially when it comes to preventative care for heart disease, for obesity in our system today, because the folks over there aren't always doing that?
So, I will always say it goes back to the patient. I think how we rethink drug prices is it goes back to when we develop clinical trials. We develop clinical trials with evaluations around endpoints that matter to the patient with respect to what do they want to see as a result of a treatment or medication geared towards their cancer. And I think that will help determine the efficacy and the value when you put the patient at the center. You're providing prescription, you're providing treatment alternatives and options that meet what they need, that meet their quality of life. Are they still able to work at the end? Are they able to have more energy? Do they have less nausea? Because we know overall survivability is important, but as people are living longer with cancer, we're understanding that there may be other situations or challenges that may arise. And I think that's what's missing, quite frankly, is just at the baseline, at the beginning, at the start of it. And the clinical trials have to be more diverse, quite frankly, as well, when it comes to understanding how patient populations may respond to a medication. We know that certain populations may respond differently, and there's an opportunity there to be more diverse, and I'm heartened by what I saw the FDA release yesterday, to be more intentional in modernizing how we develop our clinical trials, to bring diverse patient populations, diverse voices, and understanding what value looks like at the beginning. And I think that can really help go a long way in addressing drug prices.
But Dr. Ellis, I see you nodding your head as we go through this process. What are your biggest concerns? What are the biggest speed bumps along the way that we should know about?
Well, a major concern, first off, the studies, absolutely. One of the things I used to say, however much you differ from being 35 years old, white male, 5'10", and 150 pounds, that's how much the drug will be off for you. Because that was the population that was being tested. No women, especially no pregnant women, no minorities. I mean, it was really that person.
To his point, one size doesn't fit all.
Correct. And when I was in the lab, I mean, we could cure cancer easily in the rat because we made basically genetic clones. And so you give cancer to that rat and then you have, a lot of time to work on it. But so access, accessibility, availability, trust. I mean, these are the things that we just need to work on over and over and over and over again. One of the problems with the studies, if your population doesn't trust you, they're not going to join the study. When I worked briefly in the Bronx, we were the largest single provider of organs for transplant in the United States because of our violence. Because it was penetrating violence. And so, when the brain dies, the rest of the body is still available. And in that population, I know of not one organ that went to our population. Mm-hmm. So we would have some families that would not donate because they say, we don't feel that we're part of this process. And so these are more than speed bumps. These are brick walls. If we had something that, talking about preventative disease, I mean, if you prevent obesity and high blood pressure, you don't have to treat the stroke. If you decrease the amount of cancer, if you do some pre-treatment, I mean, not pre-treatments, but, screening. I mean, right now, how many people here over 45 have had their colonoscopy? How many women have had their mammograms? How many of the guys know their PSAs? I mean, these are things that we can just do. And if you're talking cheap, that's cheap.
But there is a real disparity, and this is your area of expertise, Professor, when it comes to those with private health insurance, employer health insurance, and those requiring public health. How do you deal with that disparity?
I think, the irony of this discussion, we're focusing on prevention. So, I came up with a solution that I thought could reduce the risk of cancer, Alzheimer's, cardiovascular disease, and a few other conditions. It was called going for a walk. And, it turns out that's really good for you. And, and then I also suggested coin-operated elevators. This would get people taking more steps, and we know that's good for people. But the interesting
Now you are aging yourself, because there are coin-operated telephones.
Yeah, actually, no one has coins, I have to admit. The point is, we don't incent, but I don't get any intellectual property for figuring out how to get people to say, and so we underinvest in the preventive side, and then we overinvest in the treatment side. And the irony is, if you develop a drug that mimics the effects of exercise, you do get patent protection. And I actually think we're going in the wrong direction because, we've got all this digital health and we've got all these other tools that we're trying to use. And are we providing people who come up with innovative solutions? And if we really want to save money in healthcare, the way to save money is to keep people out of the hospital. If you can figure out how to do that, we should be rewarding that. And if you look at Medicare generally, that's what drugs do when they work best. They keep people out of the hospital. And we are negotiating those prices. At the same time, we are not solving these preventive health care issues that will drive disparities and costs.
So you go for a walk daily?
I do with my dog, yes. There's my solution. And if you want my dog, he's yours.
For either one of you, though, again, it goes back to the issue of striking that balance, of making sure that we don't stifle the innovation that we have in this country, have that ability to create these new drugs, orphan drugs, and maintaining the costs of them.
So, yeah, I did want to just piggyback 1 second on what he said about prevention, because I think they made a really good point about prevention, and then I'll answer your question. Sure. Because I do think if you can find it earlier and treat it, the outcomes are better. And so one example in the cancer space, when we think about early detection, for example, we know that there's an opportunity with the MCED Medicare Coverage Screening Act, an opportunity, to do through one single blood draw to see if there's a cancer signal for many. Right now we have about 5 cover screenings. And we know that there are a lot of disparities, right, with respect to access to those screenings, as he mentioned. And so that's an opportunity to kind of, equalize the playing field with respect to all populations being able, and this would be more of a Medicare focus initially, to get access to those type of screenings to see if they do have a signal, they can have additional testing, and if there is, they can catch it early. Earlier treatment, early detection can lead to better health outcomes. So I did want to share that. In the cancer space, when we talk about innovation and striking that balance, so I wasn't ignoring what you're saying. It's a delicate balance, and it's really important. But what I say, I will always go back to, we don't want to disincentivize or discourage manufacturers from trying to identify other opportunities to treat individuals or find other conditions for which their treatment might work. And so what I go back to is what I always say. I think the way to work is it's a coordinated approach. It's not just a one-step approach. I think it requires, again, working with the patients, understanding, what really matters to them, because what we don't want is that downstream effect of, if they're disincentivized to do R&D into particular areas, the prevalence of that condition or that disease, like cancer, for example, may increase, may exacerbate, and lead to higher mortality. And we don't want that. And so while this may not be an easy answer, or a popular answer, I'll always go back to, I rather work with the manufacturers and coming up with solutions to preserve innovation. And again, I say that starts with keeping the patient, at the center of the conversation. Because when you keep the patient at the center of the conversation and you understand what matters to the patient, how you look at value and how you look at outcomes are very different. Clinical benefit, economic benefit, well-being also, has a really big part in all this as well. So I always will return it back to bringing the patient into the conversation to ensure that they have a robust array of medications and options.
You want to follow up, and then I have a question for Dr. Ellis, but go ahead, Professor.
Yeah, it's related to two things they said, which is, so a lot of people have, and you asked a question earlier about Europe and what we can learn from that. Think about what we've done in HIV prevention, because, now we have, and there's been a lot of distrust. I did my early work in HIV, and there's a tremendous amount of distrust, but now you can prevent HIV in high-risk populations with a shot or a pill once every month or once every 6 months, rather than, HIV treatment, which at the time when we first discovered it was 15 pills that had to be titrated daily and had to be linked to how much cholesterol was in your meal, and we saw huge disparities. And now we can treat HIV in Africa, 1 pill a day, and we can prevent it.
And that's just in the span of about 20 years, right?
Yeah, exactly. And it's a remarkable, and that's the time frame we have to be looking at this. But my concern is, if you go to a European regulator and you say to them, look, here's a treatment, it's 15 pills a day, and the only thing I've done is I made it once every 6 months. The way regulators look at value right now, and this gets to the patient's perspective, they say there's no difference and just give me the cheapest one. And usually the cheapest one is, and what happens is you end up with these disparities. And so when we think about patient perspective on value, we have to take into account all these issues that both of my colleagues are talking about here, which is convenience, accessibility, and trust, and adherence. So anyway, that.
You wanted to follow up?
I did. Just, we're talking about we have to do both. If you have a chance, you should look at Lyndon Johnson's last speech. He was having such tremendous chest pain that he was putting in so many nitroglycerins that they're actually falling out of his mouth. Mm-hmm. And that was the only treatment we had. So
1973.
And it's a tremendous speech, and his hair was long and curly. He looked good, other than the heart pain.
And he was young. He was only in his mid-60s.
Yes.
He looked a lot older, but he was relatively young.
And now with cholesterol medication, beta blockers, calcium channel blockers, we have this whole array. So there will always be the need for the acute treatments. But we want more people to delay that as long as possible.
We may have a question from the audience, but I want to follow up on something, Dr. Ellis, because we've been talking about the drug pricing issue, but let's talk about the political side of the issue, because as you well know, Congress is broken. There's very little incentive to cross the aisle and work across the aisle. The good news is this is one of those issues that is bipartisan. What are your thoughts about the public policy role in all of this, and Medicare in particular when it comes to drug prices and trying to control drug prices?
The best thing that happens for drug prices and the control of this whole issue is that every one of us will be using it. It's not something that I will be doing for me because I'm going to need this, but you're not going to. Even we're talking about orphan drugs or these other issues, there's always going to be somebody. It won't even be 6 degrees of separation. It will be 3 degrees of separation for anything that you can think of. For pancreatic cancer, for colon cancer, for Alzheimer's, for renal disease, for liver disease, for hypercholesterolemia. Mm-hmm. There will always be something. And so that's going to be our best tool to get everybody on the same page to move this forward.
So to that point, if we were to sit here 10 years from now, what will we be talking about?
I think what I would like for us to be talking about is that the first iteration of the IRA, and I'm calling it iteration, brought everybody together, brought the stakeholders together to have start having some real meaningful, tough conversations about how we can continue to make drugs affordable, but also accessible at the same time, and bringing together diverse perspectives, but really centering that conversation around the patient. And that it may have been tough. There may have been some negotiations and some points of contention, but what that did was it really helped to bring everybody on the same page and to start being forward thinking about what can we do collectively to support the sustainability to quality medicines for all people who need them.
I'm going to give each of you a minute in a moment for a final thought, final word, but we have a question or two from the audience. Where is that?
Back here.
Yeah.
Hi. We have one from Diane Pajula from the American Psychological Association. She asks, how will the 2025 changes to Medicare drug costs for beneficiaries impact Part D plans coverage and formularies?
Do you want to take that one, Professor?
Yeah, I think there are two things. Plans are more at risk for very expensive medications, and so we're going to see more formulary restrictions. If we end up with rebate reform, which you also discussed on a
So what does that mean?
rebate reform, what it means is that 30% of what we pay for drug costs right now go to people who do nothing on the innovative side. It's 3 companies, and a lot of so it's hard to follow the money because some of it goes into Switzerland and elsewhere. But basically, people extracting from the distribution chain about 35%. So we think when we buy insulin at the pharmacy that it's all going to the manufacturers. In fact, it goes to companies like Express Scripts and the like. That is also a bipartisan issue, and they want to get rid of those rebates. If they get rid of those rebates, what are these companies going to do, to answer the audience question, in order to still make that profit? They're going to restrict access even further. So my concern is that the future for us under a very stringent IRA is restricted access for older Americans in terms of treatment.
Another question, thank you.
We have one from Ronald Taylor. Many providers advertise openly that they will take Medicare. However, when one calls for an appointment, they say that this payment option is not available. How can this be mitigated?
Dr. Ellis, are you familiar with that?
Yes, and it's a little bit sleazy on the doc's part. So the medical boards are starting to look into that. And so what they'll say sometimes is, we accept all insurances, but they actually don't. What they do is they have the patient pay fully, and then they will do all the paperwork, and whatever the insurance company pays to the patient goes directly to the patient. So if it's a $200 bill and the insurance company will pay $35, well, the doc doesn't have to try to get the $165 from the patient. The doc gets $200 from the patient, and the patient then gets a $35 check from the insurance company. So the cure for that, which is not going to happen in the United States, would be universal health, better signage, better communication, and repercussions for the docs who say those kind of things. And one of the things you can do is then compel them to take it. You said you're taking Medicare. You have to take it, and you'll have to take that amount of reimbursement, and then you'll be surprised just how quickly that website will change.
Thank you all for being with us, and I want to give you a moment with a final thought, but this has been a terrific panel. You've added so much to the conversation. So as we think differently about drug prices, Denise Ciccone, we'll begin with you. Same question to all 3 of you. How should we think differently?
We should think differently. I like what Dana said earlier. I think one way we can think differently about drug pricing, about healthcare in general, is focusing more on prevention, thinking differently, including those social drivers of health that impact, looking at the person, being more person-centered, thinking more holistically, and how we can, on the front end, as Dr. Ellis said, keep people healthy. So if they do need, the medication, we know that the lifestyle changes would have been such that it was more sustainable to keep that person healthy. So I say we can think about drug pricing differently by, continuing to be patient-focused, patient-first, and bringing in those social drivers of health that we know have an impact.
And take a walk. Dr. Ellis.
I think we need to think about this, that we all have a dog in this fight. So yes, it's great if we can cap the price of insulin and the $2,000 for the cap for the seniors. But we also have to understand that we all, through our taxpayer dollars, through our other choices, we all have a dog in this fight, and that we also, as consumers, need to be part of this decision making. As you were saying, it might be worth paying a premium not to take a pill 4 times a day, not to have the nausea, not to have these other issues. But then it also might be, I don't mind, if this pill is a little bit larger, or if I have to take 2 pills instead of 1, and that'll save the system $50, $100, 50%. We need to be part of that discussion, and we need to be making some of those practical, cogent decisions.
We began with you. We will conclude with you. You get the final word, Professor.
Thank you. I love that. How did we get here? We got here because we spend a lot in the U.S. and we don't think we have very good outcomes. And spending is price times quantity. And it is really easy for regulators to legislate on price. They set prices in Medicare, they want to set prices for drugs. But I actually think the real savings will come from reducing quantity. And as I said, it's reducing how often people are hospitalized and reducing the need to use expensive things that do little good, so that we can preserve the monies to pay for the rare stuff that people need when they are catastrophically affected.
Thank you all so much. A marvelous conversation. Thank you for being with us. And we'll turn back. Joe, final word.
That concludes our program for today. I just want to thank all of our excellent panelists. I'd like to thank Steve Scully for moderating today. I'd like to thank the Alliance for Aging Research for sponsoring us today. And on behalf of the Alliance and the Hill, I'd like to thank everyone for coming in the room and those who joined us online. If you missed any part of this or want to watch it again, this will all be posted on the Hill at thehill.com. We hope to see you all again soon. Thank you very much.